Good evening, everybody, and I would like to welcome you in our last part of the course, virtual course about heart failure and reduced ejection fraction. This course was directed by Professor Ahmed Shawqi, my colleague and the executive board member of IAVA Society. I think it was a very successful course. I enjoyed all the presentations and the cases, and I hope you will do so. I would like to thank AstraZeneca for their continuous support to the activity of IAVA Society, and specifically for this course, and of course ICOM for their technical management. My co-chair today is Professor Mohammed Salim from National Heart Institute. Professor Mohammed, Fadl.
Thank you, Dr. Ashraf. Welcome, everybody. It's a new wave or new version of our Hfref program. Today we have two very interesting subjects. We will start by Professor Atif Al-Bahri, Professor of Cardiology, Boursaid, and he is a Vice President of IAVA. He will give us very interesting talk about the management of heart failure in patients with ischemic heart disease. Professor Atif.
Thank you very much, Professor Mohammed Salim and Professor Ashraf Reda, and thanks for Professor Ahmed Shawqi for the program and AstraZeneca for the supported unrestricted grants program for Hfref. I am delighted to welcome everyone. Our presentation today is management of heart failure in ischemic heart disease. My agenda is one personal history of a case and examination, treatment, and take-home message. Our patient is Mr. A.M., is 65 years old male. He is clerk, hypertensive, receiving atenolol beta blocker, smoking for the past 30 years, and have chest pain of 60 minutes duration. On examination, his blood pressure is 150 systolic, 70 diastolic millimeter mercury, and heart rate is 54. Heart rate is 54 beat per minute, regular and left and 30 peripherally. He has a mild bilateral lower lung edema, has a lung auscultation clear, elevated GVP. The apex is in the fifth intercostal space at the anterior axillary line and have apical systolic murmur. Do you hear me?
Yes, yeah.
Yes, Dr. Atif, yes.
Okay. My first question here, what is the immediate procedure to be done? An ECG, or making a troponin, or making echocardiography, or chest X-ray? This question is for the audience. أكمل ولا أنا مش عارف هيطلع حاجة ولا؟
مش عارف عند سليم طالع سليم في أي results لل.
So far, I think Ziad will give 30 seconds for the audience to answer, and in the host camera, still no answers came. We have to wait for 30 seconds, I think.
Otherwise, you can continue discussing the case.
Go ahead, Professor Atif.
Okay, so the recommendations here, as we see, for diagnosis, risk stratification, imaging, and risk monitoring a patient with suspected non-ST segment elevation control syndrome. The guidelines, it is recommended to obtain 12-lead ECG within 10 minutes after first medical contact, and to have immediately interpreted by an experienced physician. This is class 1B. Also, we should have also high sensitivity troponin, class 1B. But the importance here in that we should make the ECG immediately within this 10 minutes. This is ECG of the patient, as we see. DVR, FL, FF, V2, V1, V1, V2, V3, 4, 5, 6. Is it clear here that we can make a diagnosis? What's your diagnosis? We see here an elevated ST segment in V1 and V2 and V3, as we see, and a depressed ST segment in lead 3.
So this ECG, Professor Atif, is clear. There is ST elevation,
Yes.
myocardial infarction, and we are
Yes.
in acute situation. Okay.
Yes. Okay. So, what is next? You have to discharge home or admit to the CCU and observe, or admit to the CCU and give thrombolytic therapy, or admit an emergent PCI or a primary PCI. This is the triage.
What's your impact, Professor Salim? What's your impact, Professor Salim?
I think this is a case of STEMI, and I think our prompt action should be admission of the patient and arrangement for the emergency primary PCI.
Okay, Professor Atif.
Okay. As we see here from this chart, this is a triage. When you have a patient with clinical setting symptoms of signs, you look for the ECG. If this ECG has an ST elevation and it's very high, the triage decision should be roll in myocardial infarction, because this is a state of STEMI, and this patient should be admitted immediately for primary PCI. And here we can see the total ischemia time. When the patient call the ambulance here, if it's STEMI, less than 10 minutes, as we see from the slide, and this is the time to PCI, less than 120 minutes, primary PCI strategy, less than 90 reperfusion wire crossing. Or if more than 120 minutes, fibrinolysis strategy is done, if less than 10 reperfusion lytic bolus. So here also we can see if less than 10 minutes and we have a STEMI diagnosis, a primary PCI strategy is very important. No delay, less than 60 minutes reperfusion wire crossing. This is the total ischemic time as we see from this chart. And here the totally occluded LDA, which was managed as we see from this. It is not moving, huh? No.
No, but it's clear.
But it is clear it is totally occluded LAD.
Okay.
So now we can see, ask another question here. On the third day, he developed shortness of breath and orthopnea. What could be the cause? Left ventricular dysfunction, acute mitral regurgitation, ventricular septal defect, or any of the above?
I think Professor Atif, Professor Salim, the message here is that first of all, this is ST elevation acute myocardial infarction. So whenever our patient have chest pain, we have to respect the chest pain because it could be a severe situation or serious situation and could be transferred immediately to CCU, because the main treatment is primary PCI. You have to go immediately, open the occluded artery to save the myocardium as early as possible. If they do this job in the proper time, I'm not expecting left ventricular dysfunction because it should be myocardium saved. However, sometimes it happened that after even opening the artery in proper timing, there is left ventricular dysfunction. So it may be in my opinion, any one of them. What about you, Professor Salim?
I agree with you, Professor Ashraf. Any one of these three choices could be a possibility. As you said, sometimes even after a reopening of the vessel, still there is myocardial stunning, maybe another mechanical complications like acute mitral regurg or VSR or ventricular septal defect. So any possibility could be the cause.
Professor Atif.
Thank you. So مش عارف ما بيتحركش ليه.
لو بيتحركش اقفل البرزنتيشن وافتحها تاني واعمل شيرنج من الاول. ستوب شيرنج وبعدين شير تاني.
ستوب شير. تمام. Okay. Here we can see the complications of myocardial infarction. As we see, myocardial infarction, as my dear colleagues stated, we have impaired contractility, ventricular thrombus leading to stroke or embolism, hypotension leading to decrease the coronary reperfusion, increasing ischemia and cardiogenic shock, tissue necrosis, papillary muscle infarction leading to mitral regurg and congestive heart failure, or ventricular wall rupture leading to cardiac tamponade, also electrical instability leading to arrhythmias, pericardial inflammation leading to pericarditis. These are the myocardial infarction complications on this patient. Here, the summary of indications for imaging and stress testing in ST elevation myocardial infarction. As we see, routine echocardiography to assess resting left ventricle and right ventricle.
For me, it's the same slides. Salim, it's changing?
Yes, it is the same slide, myocardial infarction and the algorithm.
I think you can stop sharing again and start again. Okay.
Do you see the myocardial infarction complications?
Yes, it's clear.
And now the display of indication for imaging and the stress testing in ST elevation myocardial infarction. Do you see it? Okay.
It's coming now, yes.
Okay, during hospital stay, after primary PCI, routine echocardiography is essential to assess resting left ventricle and right ventricle function to detect early post-MI mechanical complications and exclude left ventricular thrombus is recommended in all patients. This is class 1B. Emergency echocardiography is indicated in hemodynamically unstable patients, class 1C. And when echocardiography is suboptimal or inconclusive, an alternative imaging method like CMR preferably should be considered class 2AZ. Either stress echo, CMR, SPECT, or PET may be used to assess myocardial ischemia and viability, including in multivesical coronary artery disease. This is class 2BC. This is the chest X-ray of the patient. If there is any comment.
Yes, Dr. Atif, I think we have an evident pulmonary congestion, evident in the increased bronchovascular markings in the hyla of both lungs.
Yes.
Congestion.
Yes. And the indication is it can predict what?
I think out of this there is no severe cardiomegaly.
Yes.
There is some hylar congestion, but for me it is not a typical picture of, for example, impending pulmonary edema or what, something like that. And of course, when in case of myocardial infarction, you don't expect a very big heart. You may have heart failure with the heart X-ray is average.
Yes, thank you. This is echocardiography. The left ejection fraction of 35% with akinetic apex, mid-anterior wall and mid-septum, mild mitral regurgitation. LA is 45 millimeter, and moderate tricuspid regurgitation. Right ventricular systolic pressure is 38 millimeter mercury. What is the commonest cause of heart failure? Ischemic heart disease, or post-infectious, idiopathic, or valvular heart disease?
Of course, in our case here, the reason is clear. This is acute myocardial infarction, and unfortunately, despite opening the artery, it seems that it is opened not in the proper time.
Yes.
maybe late
Yes.
late presentations. So it's ischemic heart disease definitely. But however, in our daily clinical practice, I think the most common cause is ischemic heart disease or idiopathic cardiomyopathy.
Okay. So the most common causes of heart failure here, as we see, is coronary artery disease resemble 70%, which is a big piece of the heart, as we see. The others 10%, the cardiomyopathy 10%, the valvular disease is 10%. So most of the common causes of heart failure in all the patients, about 70% coronary artery disease, and it comes after that hypertension, valvular diseases or cardiomyopathy, idiopathic cardiomyopathy, alcoholic cardiomyopathy, toxin-related cardiomyopathy, adrenomycin or postpartum cardiomyopathy, hypertrophic obstructive cardiomyopathy, or tachyarrhythmia-induced cardiomyopathy, infiltrative disorders like amyloidosis, congenital heart disease, cardiac disease, hyperkinetic states like anemia, arteriovenous fistula and beriberi, but we should concentrate here that the most common cause is coronary artery disease. In addition to the antiplatelet therapy, as we see here, ticagrelor, aspirin, and statins, what would you add? RAS inhibitor, beta blockers, diuretics, MRAs. Dr. Selim.
Yes, Dr. Atif. In this case, I think if the patient is dyspneic and there is an evidence of congestion, I think we have to start by diuretics to relieve the congestion. This is the first possibility. This is the first choice. This will be followed also by addition of RAS blockade and beta blockers. But here, if there is a congestion and the patient is dyspneic, I think the first choice is diuretics.
Agree with you, Professor Selim and Dr. Atif. I think we are dealing with a case of heart failure with reduced ejection fraction. And the main pillar of treatment of heart failure with reduced ejection fraction, the four main pillar of treatment, as you know, as Dr. Atif will show us now, is RAS inhibition, whatever the type, SGL2 inhibitor, beta blocker, and mineralocorticoid blockers. Of course, diuretics now is class 1 indication to reduce heart failure symptoms. Dr. Atif?
Routine therapies in the acute, subacute, and long-term phases here of failure, as we see, ACE inhibitors and angiotensin receptor blockers are recommended starting within the first 24 hours of STEMI in patients with evidence of heart failure or left ventricular systolic dysfunction, diabetes, or an anterior infarct. This is class 1A. And the MRAs are recommended in patients with left ventricular ejection fraction less than 40 and heart failure or diabetes who are already receiving an ACE inhibitor and a beta blocker, provided there is no renal failure, hyperkalemia. This is the class 1B. But these guidelines are old from 2017, as we see. And here we can see مش عارف ليه بيتعطل كده. Beta blockers, oral treatment with beta blockers is indicated in patients with heart failure or left ventricular ejection fraction less than 40% unless contraindicated. This is class 1A. As we see here also, intravenous beta blockers should be considered as a time of presentation in patients undergoing primary PCI without contraindications, with no signs of acute heart failure, and with an systolic pressure more than 120 millimeter mercury. It's class 2A, level A. Routine oral treatment with beta blockers should be considered during hospital stay and continued thereafter in all patients without contraindications. This is class 2A, level B. Intravenous beta blockers must be avoided in patients with hypotension, acute heart failure, or AV block or severe bradycardia. This is class 3, red, level B. If this patient, as we see here, this patient 1 month later, he's still dyspneic, but not congested, in spite of 10 milligram ramipril and 100 milligram metoprolol beta blocker and 25 milligram ipilimumab. Heart rate is 65 beat per minute. Blood pressure is 110 systolic, 65 millimeter mercury diastolic. What could we add more for this patient? Hydralazine, SGLT2 inhibitors, diuretics, digitalis.
I think Dr. Atif here is the fourth pillar of the heart failure treatment class 1 indication, which will be the SGLT2 inhibitor to be added. Hydralazine is added in a very special situation after the 4 pillars in Black patients or African American patients when other measures or the patient is still symptomatic, while the other 2 choice diuretics, the patient is not congested, and digitalis comes as a class 2B, may be indicated only in patients with rapid or uncontrolled atrial fibrillation. So
and I want to ask Professor Hfref, would you replace ACE inhibitor ramipril with ARNI, sequetril, valsartan?
RAS inhibition should be part of our treatment. And RAS inhibition means ACE inhibitors, ARBs, or ARNI. Of course, ARNI is better in a way or another than ACE inhibitor or ARBs because it has the evidence and it can be upgraded the dose in a short time. ACE inhibitor may be needed to be to reach the maximum tolerated dose of ACE inhibitor. It may take time. However, this patient is already on ramipril 10 milligram per deciliter, so he is on a good dose of ACE inhibitor, and despite that, he is symptomatic. So I think the first choice is to give diuretics and SGLT2 inhibitors. You may replace after that the ACE inhibitor with ARNI if the patient is still symptomatic.
Okay. These are the 2021 update to the 2017 ACC expert consensus decision pathway for the optimization of heart failure treatment and the answers to the 10 pivotal issues about heart failure with reduced ejection fraction. We can see here that for patients with persistent volume overload, overload, we have class 2 to class 4, if you have to titrate the diuretic agent. And for patients meeting the eGFR criteria, in NEHA class 2 to 4, you can add on SGLT inhibitor as we see. So we think here that the patient, by adding the SGLT2 inhibitor, we can perform the guidelines as we see. Here, the ECC, European Society of Cardiology guidelines, 2021 guidelines, clinical recommendations. We can see here the ACC heart failure guidelines, 2021 management of Hfref, phenotypic overview. To reduce the mortality for all patients, you can prescribe ACE inhibitor or ARNI, beta blockers, MRA, and SGLT2 inhibitors as the 4 pillars to reduce the mortality for all patients. To reduce heart failure hospitalization and mortality for selected patients, if there is volume overload, you have to add diuretics. And if the SR with left bundle branch block more than 150 millisecond, and there is atrial fibrillation, you can add anticoagulation. Here we can see if there is ischemic etiology and coronary heart disease here, and the heart rate is more than 70 beats per minute, you can add ivabradine. In plaque races, adding hydralazine or nitroglycerin. If there is a non-ischemic etiology, iron deficiency anemia, you have to add ferric carboxymaltose. So you have here the main things for above is to reduce the mortality by using the 4 pillars and to reduce the hospitalization mortality for those selected patients. The take-home message, as we see, ischemic heart disease, especially acute myocardial infarction, is the most important cause of heart failure. Immediate diagnosis and management is the paramount, as every minute that goes by, a part of the myocardium is lost. And the algorithm of management does not differ from Hfref, as we see, with proposed sequence of medications to be used when stable. And thank you very much for your attendance and viewing.
Thank you, Professor Atif.
You can stop share, Atif. And I think, Dr. Selim, you can give insight on this case in 1 minute before taking a 30-second break and starting the second presentation.
Okay, thank you, Professor Atif, for this elegant case presentation. I think you gave the message very clear that the management of Hfref in a patient with ischemic heart disease, as long as there is no residual ischemia or no indications for revascularization, regarding the pharmacotherapy, it is exactly the same like Hfref from any other etiology. And you demonstrated very elegantly the starting of medications, the up-titration of those, the starting of diuretics to relieve the congestion, and the 4 important pillars which will change the mortality and decrease the rate of hospitalization in the patients with Hfref of ischemic etiology. Thank you again, Professor Atif, for this very clear presentation. And I think now we will go for a break for 1 or 2 minutes, and then we will come to the next presentation. Thank you, everybody.
Selim.
Welcome everybody to the second part of our meeting today. Now, our dear professor, Professor Hfref Reda, Professor of Cardiology, Munufaya University, and the President of IAVA, will give us very important lecture and very practical one, which is the Hfref management in a patient with slow heart rate. Professor Hfref.
Thank you, Professor Selim. Thank you, Professor Al-Bahari. Actually, this is another case. We'll try to see the problem of having a patient with slow heart rate if you need treatment of his heart failure. But let us start the case first. The agenda is personal history.
Professor Hfref, did you share your, because I cannot see the slides?
Very strange. So let me stop sharing.
Okay, we can try again.
دكتور أشرف اتفضل.
Welcome again, and the agenda of this presentation is first the personal history, and then the result of examinations. We will discuss after that the treatment options, and lastly the take-home message. This is our patient, 72 years old male. He is pensioner, hypertensive, and receiving amlodipine. He stopped smoking 5 years ago. He is complaining of swelling of the ankles and lower limbs for the last 2 weeks or of 2 weeks durations. So these patients coming to you in your clinic has a history of long-standing hypertension. He is receiving amlodipine and having swelling of his ankles of 2 weeks durations. So I think now we should think about what is the cause of swelling of his ankles in view of the long-standing hypertension and the presence of amlodipine in the treatment. On examination, his blood pressure is not well controlled, is 150/70. As you know, it should be less than 120/80 or at least less than 130/80. His heart rate is 54 per minute, regular. This is a problem here because with this heart rate, it's difficult to prescribe beta blocker or rate lowering medications. On examination, he has mild bilateral lower limb edema. And of course, it may be due to amlodipine, it may be due to other causes, maybe due to heart failure, whatever. So till now, it is not easy to think about heart failure till this now. Lung auscultation is clear. He has elevated jugular venous pressure. Here one can starting to think about whether this is heart failure or not, because bilateral beating edema plus elevation of the venous pressure here is the question mark. The apex is in the 5th intercostal space in the anterior axillary line. This is the normal apex, so we don't have evidence of severe left ventricular dilatation. And we have apical systolic murmur, which, as you know, may be due to mitral regurg, for example. So now examinations, in addition to the history, the main problem here is some edema in both limbs, some elevation in jugular venous pressure, and a little bit uncontrolled blood pressure. So what are the differential diagnoses? And for the audience, you can press now vote and choose your answer, whether this is amlodipine effect, is it heart failure, it is part of generalized anasarca, it is others. So what is your first impression, dear attendee? We will wait for 15 seconds to see the results. And if the results is in front of you, Dr. Selim, you can comment. If not, okay, you can comment by your own.
Okay, just we will wait for 15 seconds. Just I want to ask you, Professor Ashraf, if the patient is complaining of any shortness of breath?
Well, it is not clear from the symptoms and from the history, and this is very important because, 72 years, hypertensive, it will not, unless the short-term breath is very severe, it will not very clear. There may be mild short breath, mild exertional fatigue, but anyway, there is no severe short-term breath or orthopnea.
Yes. So far, there are no any other answers came in front of me. So I think we have to comment. I think, Professor Ashraf, the two possibilities only we have.
I have some percentage here. Heart failure 80%, and amlodipine 20%.
Yeah, it's good because I think it comes in accordance with the correct answer because we have high jugular venous pressure. in these patients. In addition to lower limb edema, I think mostly it will be a heart failure. The cause
despite I may agree about the confusion of some of us, 20%, that it may be amlodipine effect, because this is one of the possibility. Of course, heart failure should be kept in mind. By the message here is sometimes heart failure is not very clear, and sometimes regular patients coming to you in the clinic, and it is confusing, especially if there is no gallopism, if there is no severe short of breath, some pitting edema and mild elevation of the blood pressures. GVP may be passed unnoticed if you don't examine the patients in a proper position and well.
We need more investigation, Dr. Ashraf.
So again, it is not, slides is not, I will stop the share and share again, like this, share screen.
Okay.
Okay, again, I share the same screen, so stop sharing, share screen. I will tell, okay. It is not working, I don't know why.
This is not the signal or the Wi-Fi, this is the template.
Yes.
Okay.
What do symptoms and signs?
Okay, we have another questions here. I think this is the slide sequence is okay. No. Okay.
We can see the slides moving, Dr. Ashraf.
Okay, so this is the last slides we was with us, and 80% of the attendee choose heart failure, 20% think it was a amlodipine effect. So what do the symptoms and signs suggest of these patients? Do you think symptoms and signs are typical for heart failure? Do you think signs are typical and symptoms are not? Or symptoms are typical and signs are not suggestive of heart failure? Or both signs and symptoms are not suggestive for heart failure? So we will wait 15 seconds. Dr. Salim with us.
It's very tricky question.
Yes, symptoms and signs typical, or one of them typical and one not, or both are not suggestive.
It may be, but
well, the main symptom is ankle edema.
Ankle edema.
And the main sign is elevated venous pressure.
But also, Dr. Ashraf, you mentioned that we have an apical systolic murmur, and in addition, I think there is mild displacement of the apex because it is not in the midclavicular line; it is in the anterior.
Oh, yeah. I missed that part. It is in the axillary line. Yeah. So yes, any results, Mu'taz, from the votes? I think we have something here.
The choice B is 33%. The choice B. Choice A is 50%.
Okay. So let us review the symptoms and signs of heart failure. And this is the main message of this presentation, is that sometimes it is not very clear to diagnose heart failure in the clinic. So let us review the symptoms. The typical symptoms, of course, breathlessness, short of breath, and orthopnea, paroxysmal nocturnal dyspnea. This is symptoms of pulmonary congestion. It's very important. Equivalent to this is reduced exercise tolerance or fatigue. However, look, ankle swelling is one of the typical symptoms of heart failure. Regarding the signs, elevated jugular venous pressure is more specific. Hepatojugular reflex, third heart sound, laterally displaced apex, as Dr. Salim noticed. So we have one of the typical symptoms, which is lower limb edema, and two of the typical specific signs, elevated jugular venous pressure and mildly displaced left ventricular apex. Of course, other symptoms and signs are less specific and less typical of the. So let us look at the laboratory results. Serum creat is 1.4. This is mildly elevated, and of course, I prefer EGFR in the assessment of the renal function, and this is important in choosing the treatment, because if the patient have significant renal function, you have to be cautious prescribing some drugs for heart failure. Serum potassium is 5.3. Again, it is above the level that safe with, for example, ACE, ARBs, or mineralocorticoid antagonist. And this is very important. Sodium 138, hemoglobin 12.9. And the hemoglobin is not enough to diagnose the anemia with heart failure. Serum ferritin is more specific. You may find patient with normal hemoglobin and low serum ferritin that deserve a treatment of heart failure with replacement therapy. TLC, total leukocyte count, okay. Platelet, okay. INR, liver enzymes is okay. This is a laboratory finding. Let us look at the ECG. This ECG, first of all, it looks abnormal ECG. We have some STT changes in lead 1, inferior and lateral leads. We have some voltage criteria, the R wave and the S wave in the anterior leads and even in the lateral leads. So we have left ventricular criteria. We may have ischemic heart disease, but this is typical of left ventricular hypertrophy actually. So I think now the pictures start to be more clear. We have typical symptoms. We have a specific sign, GVP, and the displaced apex. We have abnormal ECG. So I think the echo should be done now, and it is conclusive. X-ray first of all, and as you see in the X-ray, there is some hilar congestion. There is Kerl's line of interlobular congestions, suggestive, of course, of pulmonary congestion and maybe pulmonary hypertension also. Oh, the echo is very clear. Look at the left ventricular cavity. It's a big left ventricular cavity. Look at the mitral to septal separation, long distance mitral to septal separation. Look at the left atrium is relatively enlarged. And this is, I think, regurgitant lesion. It looks like tricuspid regurg, significant tricuspid regurg, and the velocities denoting some pulmonary hypertension, significant. So the results of the echo, left ventricular ejection fraction, 38%, mild mitral regurgitation, enlarged left atrium, and moderate tricuspid regurg with significant right ventricular systolic pressure elevation, significant pulmonary hypertension. So now, pulmonary hypertension, what is the differential diagnosis of pulmonary hypertension here, or situations? Pulmonary hypertension may be the most common cause. It results from left ventricular failure, pulmonary hypertension, right ventricular failure, and systemic edema. It may be lung disease, of course, can cause pulmonary hypertension. Idiopathic pulmonary hypertension may be the cause. Recurrent thromboembolism in the lung may lead to pulmonary hypertension. But however, here the picture is clear from the symptoms, from the signs, from the echo. This is case of left ventricular with reduced ejection fraction, pulmonary hypertension, systemic congestion is clear from the signs of elevated GVP and ankle edema. Let me ask you a question. This patient is on amlodipine for the treatment of hypertension. Is amlodipine contraindicated in heart failure? Please vote, my dear attendee. We'll wait for some seconds. And Dr. Salim, if he has some results, he can tell us what is the opinion of the attendee.
I am following the voting results, but so far nothing.
In the chat, we'll find some results from Mu'taz if it is not clear in your screen.
It did not come yet.
So if it is problem in the screen, we can go to the some comments on the drugs compelling indication and the contraindication for the major classes of antihypertensive drugs, because it's hypertension, as Dr. Atif explained to us, is one of the important cause of congestive heart failure, long-standing hypertension. So we have to deal with patients taking drug for hypertension and maybe a developed heart failure. So, for example, the class of drug alpha blocker, compelling indication, prostatism, compelling contraindication, urinary incontinence. And ACE inhibitor, compelling indication, heart failure, left ventricular dysfunction, of course. Compelling contraindication, pregnancy, significant renovascular disease. ARBs indicated when cough induced by ACE inhibitor are there, and contraindicated pregnancy, significant renovascular disease. Beta blocker, of course, myocardial infarction, angina should be giving beta blocker. However, as asthma, COPD, or heart block may be compelling contraindication. And remind you that our patient has a heart rate of 54 per minute. So if you want to add beta blocker, it would be very cautiously. And calcium antagonist dihydropyridine indicated should be given in isolated systolic hypertension in the elderly patient, and calcium antagonist rate limiting like verapamil indicated if angina, contraindicated for heart failure and heart block. Thiazide, of course, elderly patient including isolated systolic hypertension and the contraindicated in gout. This is the drugs used in hypertension and their compelling indications and the compelling contraindication. And let us look at the guidelines regarding amlodipine. Amlodipine is recommended when hypertension persists despite treatment with a combination of as many as possible of an ACE inhibitor or ARB, beta blocker, MRA, and diuretics. Those is class 1. So it is not contraindication actually, but it's better to give ACE, ARBs with amlodipine, beta blocker, MRA, diuretics. And they should be considered when hypertension persists. Felodipine also, but felodipine is class 2A. Yeah, it should be considered, but amlodipine is class 1A when the hypertension is not responding to the usual treatment. Sorry.
So, Dr. Ashraf, I can ask you, so amlodipine in this patient is not the preferable choice. However, it is not contraindicated.
Yes, agree with you.
Yes.
Of course, this patient is having heart failure, so it's more beneficial to the patient to give ACE, ARBs, diuretic, SGLT2 inhibitor, ARNI. However, if the blood pressure is persistently high, 150 or above 130 or 130, it's better to control the blood pressure, and here it will not be contraindication. So what would be, again, the initial therapy for this patient? ACE inhibitor and the small dose beta blocker. ACE inhibitor concern is renal function, concern is high potassium, beta blocker concern is the heart rate. ACE inhibitor and ivabradine. I will not give ivabradine for a patient having a heart rate with 54 per minute.
Yes.
ACE inhibitor and MRA, this combination is difficult because the potassium is 5.4. ACE inhibitor and SGLT2 inhibitor, this is two of the main 4 pillars of heart failure. It's a good combination. So I think the choice is between A and D, either to give ACE inhibitor and small dose beta blocker, or if you are not afraid of giving the beta blocker for a patient with some sinus bradycardia, I think D is very ideal choice, because it, as I said, these are 2 pillars in the treatment of heart failure. Any voting?
Yes, Dr. Ashraf, about 80% of our audience gave the choice D. However, the surprise, the remaining 20% giving the choice C. So we have to stress again about the presence of high potassium in this patient.
So this is a very important message here. The message is we cannot give all heart failure patients the same treatment. You should look at your patients, the risk factors, the laboratory finding, the echo, and then choose your treatment. Because if there is renal dysfunction, you should consider. If there is high potassium, it should be considered. The heart rate is very important. So don't give drugs because they are indicated. But the patient's situations and the laboratory finding may actually leading you to certain preference of some drugs. All of them are used in heart failure, of course, and all of them are beneficial in heart failure. But for each specific patient, you have to. And SGLT2 inhibitor, I think there is no contraindication of SGLT2 inhibitor, whatever, except if the severe renal dysfunction may be below 15%, 15 eGFR. And even those who are below 30 eGFR could be received SGLT2 inhibitor. So regarding bradycardia, no contraindication for SGLT inhibitor. Renal dysfunction, if it is mild or moderate, there is no problem. And I think regarding the potassium, also there is no problem. So I think the correct answer here, according to our patient, is D. Because the heart rate is 54 and the potassium is 5.3. Do we require diuretics in this case? We are waiting for the results, and after the results, I will show you the guidelines and the indication of diuretics in patients with heart failure with reduced ejection fraction. Any results have arrived?
Not yet, Yamish.
Okay, let me continue while they are voting.
100% of our audience giving the answer yes.
Okay, so this is the role of diuretic in heart failure. It is class 1 indication using diuretic if your aim is to improve symptoms and exercise capacity. So if there is significant short of breath, fatigue, low workloads, here diuretic is class 1 indication. It is class 2A if your aim is to reduce hospitalizations and the patient has signs and symptoms for congestion. So actually diuretic is important, especially if there is symptoms of congestion, if there is significant short of breath, low work capacity, and also it should be considered if your aim is to decrease hospitalization of heart failure. So at least mild diuretic may be needed if there is no severe short of breath, at least to reduce the heart failure hospitalization. Sometimes we don't think about the device therapy in heart failure. Device therapy in heart failure may be needed in some situations. Do we need this device therapy, synchronization therapy, CRT, in these patients? Yes or no? Sometimes, as you know, CRT is used in heart failure patient and may improve, decrease hospitalization, improve symptoms, and may even improve mortality in some patients with heart failure with reduced ejection fraction. Do we have the criteria to send this patient for CRT?
We are waiting for the answers.
Yeah, okay.
100%
no.
No. 100% no. Yes.
Okay, I think this is there's a good the typical answer, the good answer, the correct answer, but it depends on you have before saying no or yes. You have to look at the symptoms of the patients, despite medical treatment. You have to look at the ejection fraction, around 30% or what. You have to look at the QRS duration in the ECG. If the QRS duration is above 150, it is indicated. Below 150, it may not. So I think this is guidelines. CRT is really contraindicated in patients with QRS duration below 130 milli per second. So it's very important, according to the ECHO CRT trial, and the meta-analysis suggests possible harm from CRT when the QRS duration is less than 130. So you must have wide QRS complex to start thinking about implantation of CRT, which is not recommended if the QRS complex is less than 130 per second. So let me finish with the take-home message in this case. First of all, heart failure is not uncommon to pass unnoticed in our daily practice or clinical, especially in the elderly, 70-something years, some pitting edema, mild GVP per patient, and he is heart failure with reduced fraction. And if you're not expecting this, if you are not looking at this, if you are not do the proper investigation, looking at the ECG and the echo, you will miss the diagnosis easily. So using the correct investigations, we can diagnose cases more accurately. And again, management, as we saw in the multiple choice questions about the drug for these patients, management should be individualized, and according to the ejection fraction, according to the heart rate, according to the renal function, according to serum potassium, the drug-drug interactions. So management is individualized according to the parameters of the patients. Lastly, this include blood pressure, heart rate, laboratory investigation, and concomitant medication should be considered. It is not something routine to give the drugs you know that it is indicated in heart failure before looking at your patients and the investigation of the patient. And then we leave the mic for Dr. Selim to conclude these presentations and if there is a question. For Selim.
Thank you, Professor Hfref. It's really very interesting and very practical case-based presentation. You demonstrated very clearly that sometimes the presentation of heart failure is very subtle. In a patient with hypertension and taking amlodipine, the presence of lower limb edema can delay the diagnosis of heart failure. I see now Professor Shawki is joining us. I congratulate him for the excellent preparation and excellent arrangement of this wave of management of Hfref. Again, Professor Hfref, after the subtle presentation of this patient, he demonstrated that the management should be individualized in each patient, and depending on the hemodynamics, the GFR, the serum potassium, we have to individualize the treatment strategy in each one. And finally, the device therapy in the last guidelines highlights the importance of the wide QRS complex and the left-bounded branch block morphology for those patients who can gain benefit from the CRT. Thank you so much again, Professor Hfref, for this excellent presentation.
So I think welcome Professor Shawki, the director of this program, and I think he can give us insight because this is the last part in this series. He can give us insights, program highlights, and his future plan for heart failure program. Dr. Shawki.
Okay, thank you all. I would just like to remind all attendees that after we finish, there is going to be a short survey, and this survey is completed, and after that you get your certificates. But first things first, I have to do an acknowledgement. Thank you all speakers. Thank you all moderators. Thank you, Professor Hfref, Professor Atif, Professor Muhammad, every single speaker and moderator. It was never going to be without you guys. I love working with the IAVA. We are a great team and we're doing it very professional. A second thanks and an important thanks to AstraZeneca. Really, the unrestricted, unconditional support that they have given us was incredible. From Dr. Ahmed Maawad, Dr. Iman, and Dr. Muhammad Hashim. I don't want to forget anybody, but I also have to have a special thanks to Dr. Ahmed Ramadan, a real dynamo that is being behind this coming to light. A third thanks, not in succession, but ICOM. You guys, you do everything really nice. Everything from preparation, from getting us the voting system, and their media production is just more than great. Thank you from Dr. Ahmed Al-Shal. We have Salma, we have Marianne, we have Tez, we have Ziad, great friend Ziad. Thank you. Mona, Randa, I don't want to forget anybody. And finally, I would like to thank all our attendees for coming with us. What we have shown is a lot of things. We've seen multiple different presentations of Hfref. Actually, this program was prepared months before even there's this position paper on patient profiling presented by the European Heart Failure Association. We've seen patients with diabetes and how to control them, non-diabetics, those with a low blood pressure, CKD and hyperkalemia, ischemic heart disease, slow heart rate. We wanted to go outside just giving lectures and trying to get real patients into your idea of thinking and how to manage them. Today, we've seen great patients, but we should remember a little bit of points that we've seen over the 3 waves. In CKD, remember, most of our medications do increase the potassium level and they do lower the GFR a little bit, but the ones that do hyperkalemia are the RAS blockade and the MRAs. SGLT2s, on the other hand, don't have that. These medications can be given regardless. We should watch out of the patients also taking different supplements or medications. This is a problem with hyperkalemia. In patients with a low blood pressure, this is a very difficult thing. And we've seen a lot of patients that we cannot up-titrate the medications because of that. We can see heart rate control by ivabradine. We can see also that we can give SGLT2s in these patients. How about in diabetes? Of course, diabetes, RAS blockade, and SGLT2s are extremely important, and these are very important to reduce heart failure and their morbidity and mortality. And even in a non-diabetic, and this was a discussion for the last couple of years, the treatment options and the 4 pillars are the ARNI or ACE and ARNI, beta blockers, MRAs, and SGLT2, regardless of the phenotype of the patient. I would like to also announce that we have an abstract in the European Heart Journal, and this is a supplement, the EAVA, or the Egyptian Association of Vascular Biology and Atherosclerosis consensus on the usage of SGLT2s in heart failure with reduced ejection fraction. And the full paper has been accepted to Cardiovascular Therapeutics and will be very soon published. And you can really take a look on tips and tricks on using SGLT2s, how to reduce the diuretic dosage, what to look at, and how to integrate different specialties together. At the end, I would like to thank you all, everybody that I thanked, and especially you as attendees. I'm waiting next year, and hopefully this is not going to be just a webinar. It's going to be a hybrid and in a much bigger, venue. And hopefully, I wish you all the best, and I wish you the best in life and health. And thank you all.
Thank you, Professor Shawqi. Thank you, AstraZeneca, my dear colleagues and attendee. And we are waiting, Shawqi, for the hybrid meeting that all of us will give you the support to be a valuable international meeting. Thank you.
Thank you.
I'd like to appreciate what my dear brother Ahmed Shawqi, because he always excited. He excites me to work. He excites me to be in the mood, because he always make a direction for everything. And thank you very much, Professor Ahmed, for what you do, and thank you, Hfref, for your guidance and your help for everybody of us. Professor Mohammed Salim, congratulations for your new position and your kindness. And thank you, Ahmed Ramadan from AstraZeneca, for the support. Of course, Ziad and all the team from ICOM. I abide what Dr. Ahmed Shawqi said about ICOM with love and gratitude for all of them.
Thank you. See you. Bye-bye.
Thank you.